My name is Rita Samba. I'm a program officer at Christian Health Association of Kenya. I'll be talking about strengthening health systems for monitoring and preventing AMR and promoting infection prevention at the community and at facility level. A brief introduction of CHAK. So CHAK is a national faith-based organization of Protestant churches, health institutions, and programs in Kenya, operating since 1946 in 45 out of 47 counties with a membership of 596. Our vision is quality healthcare for all to the glory of God. A brief overview of AMR burden. So antimicrobial resistance occurs when microorganisms change and become resistant to medicine, making infections harder to treat. And we are seeing currently standard treatment for common infections are losing effectiveness due to the rise of multi-drug resistant organisms, which we are calling superbugs. And so increasing community vulnerability to infections that lead to severe illnesses and even death. And so AMR is an urgent global public health threat that directly causes about 1.14 million deaths a year. The situation is getting worse as it is projected that AMR-related deaths will increase by 74.5% between 2025 and 2050. Kenya has not been left behind as it has the 28th highest age standardized mortality rate across 204 countries in Africa. And the main drivers in Kenya are misuse and overuse of antimicrobials, a lack of clean water and sanitation, poor infection prevention and control. There is inadequate provision of antimicrobials and diagnostic capacity for AMR, and lastly, lack of awareness and education on AMR. To address this, CHAK, in partnership with the Economical Pharmaceutical Network, implemented two projects over 2022 to 2025 with the goal of strengthening health systems to combat the spread of antimicrobial resistance through optimizing the use of antimicrobials and improving IPC practices. This was done in 45 member health units, 25 primary health facilities, which at least were providing maternity services, and 20 secondary and tertiary facilities providing specialized care across 28 counties and surrounding communities. And the approach used was One Health approach, which is collaborating and linking human, animal, and environment to address the full spectrum of disease control. The first objective was strengthening health systems for antimicrobial stewardship. This is where CHAK conducted capacity building of 407 AMR champions. This was done through blended learning, which is physical learning and online learning platforms supported by EPN, and the trainings are on preventing antimicrobial resistance and antimicrobial stewardship. These champions in turn conducted modular CMEs at facility level, as well as conducting mentorship and OJT. Also, the champions formed interdisciplinary, interdepartmental committees, which comprises of hospital departmental heads and health management team. These are people that are in a position to make decisions and even implement interventions. And the committees were drug and therapeutic committees, prevention and control committees, quality improvement committees that answer to antimicrobial stewardship committees at facility level. And these AMS committees at facility level will report to the the County Antimicrobial Stewardship Interagency Committee. This led to establishment and strengthening of antimicrobial governance and coordination at the county and facility level. One of the challenges faced here was inadequate resources to support AMR interventions. This was because some of these committees had come up with action plans, and some of the actions were really required resource intensive in terms of finances, and so the project could not be able to address all those actions. And the other challenge was limited human resources and staff turnover. And this is a challenge that we are facing in faith-based organization, seeing that after training, our healthcare workers go looking for greener pastures in government and other facilities. And so CHAK would continually train these healthcare workers, the new ones, through mentorship and OJT, as well as enroll as many healthcare workers as possible in the online platform, since it was free, so that learning continues to take place. The other area was strengthening health system for antimicrobial monitoring and surveillance, and this was done through prescription assessment and audits, where CHAK developed standard prescription assessment tools to be used by DTC and AMS committees to monitor antimicrobial use as well as antimicrobial resistance patterns at facility level, which led to a decrease in antibiotic use from 56% during baseline to 33% during endline assessment, comparing to WHO recommendation of 28%. And this was very key that a faith-based organization, even though they're not for profit, they rely on the subsidized cost of services at the facility and the sale of drugs for them to meet their running costs. And so decrease in antibiotic use would mean a decrease in income, but of course there was improvement in terms of quality. The other success was development of hospital drug formulary to guide antimicrobial use and reserve antimicrobials. And this was huge in FBO facilities, considering that they receive donation of drugs from overseas and other partners. And so these drugs are at a risk of being overused or misused. And so having a drug formulary was key to guide on AMR use. Culture and sensitivity test was another area where CHAK supported 15 secondary level facilities to conduct culture and sensitivity tests, of course advocating for definitive infection management. And for the other facilities, they were linked to government and private labs with established MOUs to subsidize cost and shorter turnaround time for these culture and sensitivity tests. This led to 35% improvement in the use of C&S test. The other area was infection prevention and control, where CHAK supported development of SOPs, IC materials, among other things. And this led to improved surveillance of hospital-acquired infection from a need basis to monthly surveillance, as well as improved IPC practices. One of the challenges faced here was data management and analysis, where we saw some facilities did not have monitoring and evaluation personnel who would be able to conduct analysis and give reports. Some facilities also had HMIS systems that could not generate aggregate data. And also in Kenya, we do not have standardized data collection tools and reporting systems. And so this really impeded on monitoring and surveillance. The other challenge was inadequate resources to support these activities. The other intervention area was strengthening health systems for awareness and education on AMR. This is where CHAK conducted awareness education, reaching 98,000 community members. This was done through change agents that are faith leaders, community health promoters, community-owned resource persons that will conduct awareness and education at facility level, and AMR champions who ensure that awareness and education is happening at facility and in different departments. This led to improved awareness and knowledge and surveillance of AMR in the community. But one of the challenges faced here was, number one, inadequate resources to support the change agents' activities. And the other challenge was poor coordination among stakeholders in One Health approach. The other intervention was strengthening health systems for advocacy and collaboration. And this is where CHAK used different platforms to advocate for antimicrobial resistance prevention. And these are the technical working groups, the CASICs and NASICs, as well as Inter-Country Christian Health Association stakeholders platform that was hosted by EPN. In addition, CHAK played a key role in implementation review of the National Anti-Action Plan for AMR containment. And even at facility level, CHAK supported signing of MOUs between government and MHU and CHAK facilities to be able to provide culture sensitivity tests, as well as collection and disposal of hazardous waste and sharps in government facilities. CHAK also used social mainstream media, cycling, and roadshow events to attract youth as advocacy platform while creating awareness on antimicrobial resistance. And this led to strategic advocacy, leading to increased budget allocation to combat AMR. And this was seen where the national and county team would put budget to support NASIC and CASIX, and at facility level, putting antimicrobial resistance activities in their annual budgets. And this, of course, fostered ownership and sustainability. The challenge faced here was lack of concrete collaboration across One Health sectors and over-reliance on donor funding that, of course, is not sustainable. The lesson learned was involving HMT is key to fostering buy-in and sustainability of infection, use of blended learning platforms which fosters quality, accessibility, and acceptability. We had data-driven decision-making to inform interventions, and this would ensure limited resources are focused on the most impactful areas. We saw also there's need to stronger collaboration, coordination among stakeholders under the One Health approach for effective intervention in preventing AMR. And lastly, there is a significant need to empower community members to prevent AMR at community level. Lastly, I want to call upon each one of us to educate, advocate, and act now to prevent and combat antimicrobial resistance. Thank you.